Hi, everyone. On behalf of the American Dental Assistants Association, I'd like to welcome you to the Impact of COVID-19 on Dentistry, Greater New York Dental Meeting 2020 virtual lecture format. My name is Natalie Kaweckyj, and with me I have Robynn Rixse. Robynn Rixse, CDA, EFDA, MADAA, BS. Ms. Rixse is the immediate past president of the American Dental Assistants Association, 2019 to 2020. Currently, she is the practice manager for Buehler Family Dental, a private practice single dentist office. In 2011, she earned her CDA as well as her EFDA, and in 2013, she became an ADAA fellow. In 2019, she graduated summa cum laude and with a Bachelor's of Science in Healthcare Administration, and was inducted to the Alpha Sigma Lambda Honor Society. She also earned her ADAA Mastership in 2019. Since 2013, she has served as the Education Chair for the Pennsylvania Dental Assistants Association, providing continuing education at the state and local level.
Natalie Kaweckyj, LDA, RF, CDA, CDPMA, COA, COMSA, CPFDA, CRFDA, MADAA, BA. Natalie Kaweckyj is a licensed dental assistant from Minneapolis and two-time immediate past president of the American Dental Assistants Association. As a busy clinician in public health dentistry and almost 30 years in the profession, Natalie finds time to share her passion for dentistry, not only lecturing nationally, but internationally as well, in addition to developing continuing education courses and writing articles. She holds a BA in biology and psychology and all 6 of Danby's certifications, and is an executive moderator for Dental Peeps Network. Natalie believes in making learning fun and uses various approaches to engage her audiences.
Our learning objectives include recognizing the timeline of the progression of the coronavirus, understanding the role of dentistry as an essential service and dental assistants as essential workers,
identifying best practices to help mitigate the risk of COVID-19 transmission to patients and team members in the dental setting, and analyzing the risk factors associated with changes in PPE requirements for all team members.
Timeline of a pandemic, the coronavirus. Back in December of 2019, on the 31st, Chinese authorities in Wuhan treated dozens of cases of pneumonia of an unknown cause. Researchers in China identified a new virus infecting in Asia. At this time, no evidence of transmission by humans was found. The week of January 1st to the 17th of 2020, Wuhan province had closed down as a result of the infections. The week of January 18th through the 24th, first cases in the US and Europe, closing of Wuhan City. And in the picture right below January 18th through the 21st is the groundbreaking of the new hospital that they had planned on making in the city of Wuhan. Week of January 25th through the 31st, first cases in many more countries began to show up. Travel bans spread globally. The picture of the airplane is one of the last charter flights leaving China with American citizens bound for the United States. The week of February 1st to the 7th, the first deaths outside of China occurred. Coordinated efforts with G7 in response, and the Chinese stock market begins to plunge. Status as of February 7th, 2020, the number of countries with confirmed cases was 25. Number of cases confirmed globally was 31,484. Total deaths worldwide at this point was 638, with the number of deaths outside of China being only 2. The week of February 8th through the 14th, the death toll surpasses that of SARS. The World Health Organization-led team heads for China, and the cruise ship cases surpass 100 cases. Status as of February 13th, 2020, the number of countries confirmed cases was still 25. Total cases confirmed globally was now over 60,000, with the total deaths worldwide 1,370. And again, the number of deaths outside of China was only 3. The week of February 15th through the 21st, the number of cruise ship cases rise. Outbreaks in Iran, Italy, and South Korea begin to occur, and more deaths outside of mainland China. Status as of February 20th, 2020, number of countries with confirmed cases, 27, a slight increase. Total cases confirmed globally was now over 75,000. Total deaths worldwide, 2,129, most of them being in China, and the number of deaths outside of China was now up to 11. Week of February 22nd through the 28th, outbreaks continue to grow in Iran, Italy, and South Korea. Travel restrictions increase. The Middle East and Europe began to wrestle with the spread of the virus. Status as of February 28th, 2020, there are now 56 countries with confirmed cases. Number of cases confirmed globally was over 84,000. Total of deaths worldwide, 2,874, again, most being in China, and the number of deaths outside of China was now up to 87. Week of February 29th through March 6th, new outbreaks began to increase in Europe and North and South America. More deaths now were outside of China. And the music festival South by Southwest was canceled. Status as of March 6, 2020, there are now 90 countries with confirmed cases. Total cases confirmed globally was over 100,000. Total of deaths worldwide was now 3,408, again, most in China, and deaths outside of China was now up to 366. Week of March 7th through the 13th. 1/5 of all students worldwide were now out of school due to the pandemic. New York City declared a state of an emergency, and the National Basketball Association canceled its season. Status of March 13th, 2020, we now have 121 confirmed countries with cases. Total cases confirmed globally was now up to 142,000. And total deaths worldwide, 5,373, with the number of deaths outside of China up to 2,197. The week of March 14th through the 21st, China reported no new coronavirus cases for its 3rd consecutive day, which was huge. Italy becomes the country with the highest death toll, mostly with its elderly citizens. President Trump signs the Families First Coronavirus Response Act into law. Week of March 22nd through the 29th, nearly 1/3 of the world's population is living under coronavirus-related restrictions. Japan at this time postpones the 2020 Summer Olympics, and the World Health Organization warns that there was a significant shortage of medical supplies. Week of March 30th through April 4th. Worldwide coronavirus cases now tops over 1 million. Over 10 million Americans file for unemployment. The Wimbledon tennis tournament was canceled for the first time since World War II. Week of April 5th through the 12th. The wet markets reopen in the city of Wuhan, China. The United States now has the most virus deaths in the world. Week of April 13th through the 20th. China reports its first economic contraction in a decade. Austria becomes one of the first European countries to reopen, and President Trump suspends immigration. Week of April 21st through the 28th, China pledges 30 million to the World Health Organization. Italy and Spain ease lockdown restrictions. Week of April 29th through May 6th, 2% of Moscow's population test positive for coronavirus. Global cases now top 3.5 million. Week of May 7th through the 14th, 3 children in New York City die of a mysterious toxic shock inflammation syndrome. Previously, it was thought that children were spared from the coronavirus pandemic. Hydroxychloroquine is proven ineffective, and global cases now top 4 million. Week of May 15th through the 22nd, China flattens its curve, the number of cases. Week of May 23rd through the 30th, U.S. deaths pass 100,000. The House Democrats vote remotely, and France pulls hydroxychloroquine as COVID-19 treatment. Week of May 31st through June 6th, various European countries begin to reopen. Spain extends its state of emergency, and Trump asks Congress for economic stimulus. Week of June 7th through the 14th, United States sees a rise in cases. New Zealand and India lift their lockdown restrictions, and China publishes its white paper regarding the coronavirus. Week of June 15th through the 22nd, Beijing reports new cluster of cases. The Food and Drug Administration revokes the use of hydroxychloroquine, and health workers begin to resign from their positions. Week of June 23rd through the 30th, Saudi Arabia places restrictions on the holiday Hajj. Vaccine trials in Africa begin, and the country of India reports a record spike in the number of cases. Week of July 1st through the 8th, cases in Brazil and the United States continued to spike. Countries impose new travel restrictions, and Africa surpasses 500,000 cases. Week of July 9th through the 16th, the World Health Organization announces independent coronavirus review. The White House orders hospitals to bypass CDC guidelines, the reuse of masks and other PPE. Moderna shows positive immune response to the virus. Week of July 17th through the 24th, China and Russia are accused of stealing COVID-19 vaccine research. India passes 1 million cases. The record number of cases is reported to the World Health Organization. Week of July 25th through August 1st. North Korea reports its first case. South Korea reports its largest daily increase since March of 2020. Mexico reports the third highest death toll in the world. Week of August 2nd through the 9th. COVID-19 cases in the Philippines pass 100,000. Week of August 10th through the 17th, Russia approves a vaccine. Moderna agrees to supply the United States a vaccine. And the World Health Organization again reports record number of new cases. Week of August 18th through the 25th, the first case of reinfection is reported in Hong Kong. New cases are decreasing in half of the United States. South Korea stops in-person instruction in over 2,000 schools. Week of August 26th through September 2nd, COVID-19 cases in Europe reach levels of what they were in March. India becomes the third worst affected country, and Latin America passes 7 million cases. Week of September 3rd through the 10th, India reports over 83,000 new daily cases for 2 consecutive days. Russia's vaccine generates an immune response, and over 500,000 US children are diagnosed with COVID-19. Week of September 11th through the 18th, India reports over 83,000 new daily cases. Again. Week of September 27th through October 4th, President Trump was diagnosed with COVID-19. Global deaths now has passed 1 million, and the NFL reported its first outbreak amongst players. Week of October 5th through the 11th, Brazil passes 150,000 COVID-19 deaths, the second highest death toll after the United States. Nepal reports 100,000 new cases overnight. Week of October 12th through the 19th, COVID-19 cases passed 40 million. Johnson & Johnson pauses vaccine trial. And Singapore and Indonesia open its borders. Week of October 20th through the 27th, France reports new daily records. India reports less than 50,000 new cases, and Italy imposes the harshest lockdown since March. Status as of October 26, 2020. Total cases confirmed globally, 43,174,685. Total deaths worldwide, 1,155,473. And the number of countries with cases is now at a record 214. November 8th, we stood at 50,708,341 cases worldwide. Deaths now worldwide was 1,261,585, and the number of recovered worldwide was at 35,769,437. So dentistry as an essential. Who would have thought? In March, when the pandemic hit the United States, it affected over 198,000 dentists and specialists in the United States. It caused a total shutdown of just about every single dental office. And those that did reopen only saw emergencies for the next foreseeable future. States had shut down at different rates. I know for myself, coming from the state of Minnesota, we shut down on March 17th and reopened 4 days later, seeing emergencies. Varying guidelines for emergent care were coming left and right to the entire dental profession. And states began reopening at varying rates. Access for patients needing oral health care. Delayed dental care because of dental office closures, and we're still seeing the backlog of this to this day. Reluctance to seek care during a pandemic. Loss of employer-sponsored dental insurance coverage, as well as other factors. Routine dental visits are opportunities for the dental team to provide preventative oral health care, such as fluoride and sealants, as well as identifying oral manifestations, a systemic disease that might otherwise be missed. A lack of access to routine dental care can also lead to untreated tooth decay or other infections. And this was one of the reasons why it was so important that dental offices see emergencies to help alleviate the chaos at the hospital emergency rooms, where most people would go for dental pain. Leaves people with no viable option other than visiting a hospital emergency room, which is costly and can disrupt the flow for those people who need the emergency care more urgently. Many emergency departments are not staffed or equipped to provide definitive dental treatment. Some will only pull teeth or write a prescription. They provide patients with temporizing measures until they can seek care at a dental office. Federally qualified health centers have a particularly important role in providing dental services to underserved populations at high risk of unmet oral health care needs. 6.4 million U.S. residents received dental care at an FQHC in the year of 2018. These dental programs were already operating on limited margins. Some have responded to COVID-19 by redeploying dental staff to frontline COVID-19 testing or triage roles, or furloughing staff, further decreasing access to care. Dental assistants are on the front lines. I could tell you I was one of 6 clinicians at my clinic that saw emergencies 5 days a week. Actually, it was 5.5 days a week. We saw half a day on Saturdays. Hour appointments, 2 columns with 2 providers, 16 emergency patients a day, day after day, for a number of weeks. Dental assistants also on the front lines at the hospital, seeing some of the more severe cases for dental needs under general anesthesia. However, since the pandemic, the number of available hours in the hospital operating room have decreased dramatically. And in other areas of care, dental assistants have stepped up to man the front desk, to document and record temperatures of patients upon intake, questionnaires about COVID symptoms, and so forth. The pandemic has impacted how dental care can be safely delivered in the short term. Will stimulate permanent changes in how dental care is delivered. We're already seeing this. We've had changes in PPE. We've had some states that have required negative pressure rooms. We have some individuals that have now adopted wearing head coverings for all types of dental treatment, whereas in the past their heads were uncovered. The profession will need to consider a number of unanswered questions. Whether the workflow and layout of dental clinics should be permanently reorganized. We find this in clinics where they have large bays, large treatment bays without walls, or perhaps only have half walls. Since the pandemic, these offices were required to put up plastic sheeting separating out each of the treatment bays. Whether expanded PPE is warranted for care of all dental patients as part of standard precautions. This is something that we will be seeing come out in the future, very near future.
All right, so this takes us into best practices, and it's important that as we're going along with all of the changes that we're seeing, that one of the things we remember is the dental community, the dental profession, the dental healthcare personnel, we do these things on a regular basis. We're seeing some changes in respiratory protocols and that type of thing, but for the most part, these are all infection control procedures that we are familiar with, and it's important to point that out. As we were going into the worst part of COVID, Natalie had mentioned her office had, closed for all but emergencies. In the state of Pennsylvania, where I'm from, there was a 10-day period where our dental offices were not even allowed to see emergency care. So it is important for the dental community to point out that we are prepared for these types of things, and we have the best practices in place to be keeping an eye on them. So a hierarchy of controls. The hierarchy is arranged beginning with the most effective controls and following through to the least effective. And they go from elimination to substitution, engineering controls, administrative controls, and then personal protective equipment. All right, so elimination is physically removing the hazard. And one of the things that we've seen that is the most being used right now as a best practice is screening patients prior to and upon arrival for their appointment. And this helps to eliminate the hazard by identifying potential symptomatic COVID-19 positive patients, allowing for postponement of elective or routine treatment. And in my particular office, we call the week before and confirm the patient's appointment, go through the screening questions with them, and then we also do the same thing when they arrive for their appointment. We ask for them to wait in their cars. We kind of refer to it from parking lot to operatory. We are changing the way that we are doing things in order to be as safe as possible and implement the best practices that we possibly can to keep both the patient safe as well as our team members. So it's also important as part of elimination to identify and remove items that could lead to cross-contamination. And this includes, for instance, magazines, newspapers, and the toys in the waiting room. But it's important to note that many offices are not using their waiting rooms right now. They are taking them straight from the parking lot to the operatories and avoiding that possible cross-contamination or the need to social distance while they're in the waiting room. And then we also need to remember that we need to clean our operatories out as much as possible. And so items that normally were being displayed in operatories, such as samples, electric toothbrushes, and other paraphernalia that were used as part of patient education materials, in many offices have had to be removed so that that cross-contamination doesn't occur and that the disinfection can be more effective. Natalie, are there any instances here that you can think of that your clinic does, or other ideas that you can include as part of this elimination step?
Trying to recall, we did have wall hangings and picture frames on our walls in our operatories. Those were removed.
Very good point. Also, not only are we screening patients, but we're also screening the staff. So it's important to note that as well, that we're asking the same screening questions as well as taking temperatures upon arrival. And one of the biggest questions as part of the screening is, are you running a fever or having felt or hot or feverish in the last 14 days? So that is definitely at the very top of that screening questionnaire. All right, the next step in the hierarchy of controls is substitution, and that's replacing the hazard. So one of the biggest areas of conversation and discussion with COVID-19 and dentistry has been respiratory protocols and the creation of aerosols. And so many offices, as they were reopening, were looking to avoid procedures that create the aerosols. So for the hygienists, that included your Kawecyjs and instruments of that sort, and instead we're going to a hand scaling situation. Monitoring the patient flow to reduce close contact between patients, as we mentioned earlier, not utilizing the waiting room, bringing patients directly from their cars to the operatory so that you didn't have a lot of interaction. And then limiting the number of visitors. For instance, many offices are not having sales reps come in. They are doing virtual discussions or virtual courses. A lot of the lunch and learns that had previously been happening are now happening virtually. And then we try to, we have seen that they're trying to limit the number of family members that come in along with the patients, just so that reduces the number of people that are in the office at any one given time. Anything else you wanted to add in this area, Natalie?
Sure. As far as avoiding procedures that create aerosols, I work for a children's clinic, and since we were unable to use high-speed handpieces as well as the low-speed handpieces, we utilized the use of silver diamine fluoride probably on 95% of the children that we had seen in the first probably 90 days of the pandemic.
Wow.
And for those instances where they did need a crown, stainless steel crown for whatever reason, we utilized the Hull technique, again, along with silver diamine fluoride, where we didn't need to prepare the tooth. The silver diamine fluoride would pretty much stop the caries progression, and then the Hull crown was able to be adapted without the utilization of burrs and aerosols. And in most cases, we didn't even have to use local anesthetic, just a little topical.
Excellent. Great points. Thank you. So the next step would be engineering controls, and that is isolating people from the hazard. So one of the biggest changes I believe that we've seen through all of this is business assistants and the evolution of their role within the new normal in which we find ourselves. So in many offices, plexiglass barriers have been put up around the front desk. We have instituted mandatory wearing of masks for anyone entering the office. That includes both staff and patients. So business assistants are wearing masks all day in situations that are very different than what they found themselves in the past. Again, offices are limiting patient volume and interactions. We are seeing the need for reducing the number of appointments just because we are extending appointment length out to make sure that we have the time we need in order to properly disinfect rooms and prepare and doff and don PPE. Rubber dam usage has been recommended as a way for isolation, as well as different systems that are high volume evacuation. I know in our particular case, we use 2 products that definitely help in increasing the high volume evacuation. One situation that we did run into when we were first returning to the office, and I actually heard that there were 97,000 of one particular item on back order because so many offices were looking to bring in these types of resources to use to cut down on aerosols. And then, as we mentioned earlier, hand instrumentation. What about for you, Natalie?
One of the things that we did when we had 2 providers working is we staggered the one provider by 30 minutes. So each appointment was an hour, but say one would start at 8, the other provider would start at 8:30, so that the overlap of patients passing one another was lessened.
Good point. And another thing that we're doing, I'm not sure if they're doing it in your office as well, but staggering lunches, just so that you're also not having that cross-contamination from staff member to staff member. Because, you know, during lunch, of course, you have to take your mask off in order to eat. So we've found people are finding different ways to go about having lunches as well. What are some of the ways that you're handling it in your clinic, Natalie?
We are also staggering lunches, and we have had to have, we're a large office, so we've had the bulk of our staff, once they came back from being furloughed, working from home, especially if they're able to do administrative work. When they did bring back majority of the clinical staff, we were able to spread out in a couple different buildings so that we weren't on top of one another providing patient care.
And we did the same. We would have people eat in different locations so that you had a limited number of people actually in the lunchroom itself. All right, so the next would be administrative controls, and that's changing the way that people work. And as we mentioned earlier, limiting access to the building. And that has resulted in us needing to put up signs. I've seen many different types of signs that have been going up. I've heard of offices that have actually chosen to lock the doors to keep patients from just walking or entering the building, and instead implementing protocols such as having them call from their car when they arrive in order to go over the screening questions. What are some of the ways that your office is limiting access to the building?
We have done the same with locking the doors. In the past, we would have many walk-in emergencies, and you know, as many as 5 or 6 a day, which is significant. And so by locking the doors, we're able to limit the access to the building.
And I think, Natalie, you would probably agree, but communication is a really big part of this, and it's just making sure that you're explaining to your patients exactly why you're doing these particular protocols. In my area in Pennsylvania, we have a large Amish population that don't necessarily have cell phones, so we have had to work around that and make sure that we can meet their needs as well. Have you guys had any type of challenges in that way?
We've had challenges in the fact that now that it's gotten colder and we're asking patients to wait in their cars, not all of our patients have their own transportation. So this poses a challenge of where they can wait until they're ready to be brought back.
That's definitely an issue, and I'm not sure if you had the same thing, but during the summer months, one of the problems we were running into were individuals that were waiting in their car and not utilizing their air conditioning. So when they did walk into the building and you took the temperature, sometimes it was a little elevated and you'd have to wait for a few minutes and retake the temperature again to make sure that it was at a correct level. Did you have that same issue at all?
We did, yes.
All right, another administrative control is to reevaluate sick leave policies. And we know that, you know, as a society, we're troopers and we come to work whether we're sick or whether we're well. And we've really had to revisit that as a profession and make sure that we let our employees, our team members, our staff know that if you're sick, it's really best to stay at home. And this has caused the need for establishing sick leave policies that are flexible and consistent with public health guidance. A great place to look for resources would be becoming familiar with the recommendations from your state and local Department of Health. They offer a lot of resources on, you know, helping to create sick leave policies that will meet the needs that we have right at this current climate. So another important administrative control is the creation and implementation of a respiratory protection program. And this is a fairly new. Natalie, wouldn't you say that respiratory protection, while we're familiar with it, hasn't really been a focus of the dental team?
Correct, and it is now more at the forefront since it's been brought, the attention's been brought that it's so important.
A really good resource is the American Association of Occupational Health Nurses. They actually offer a certificate program where you can get respiratory protection program certificate in it. And that is something that's very important. Our offices are used to having infection control coordinators, OSHA compliance officers, and I believe that right now you're seeing a great need for a respiratory protection program manager to fit into that category. Would you agree, Natalie?
I definitely agree with that.
All right, so you also are going to need to review your scheduling and adjust for optimal patient and team safety, as Natalie and I both have mentioned, and extending appointments to allow adequate time for PPE changes and additional cleaning and disinfecting procedures. As your CDC guidelines have adapted and interim guidelines have been put into place, you've seen a change in the length of time in which you need to have a room sit in order to allow your droplets to fall, and that has changed. Natalie, what do you see as the biggest change there that dental team members should be aware of?
Well, it went from 30 to 45 minutes many months ago to as little as 15 minutes now, depending on how much aerosolization there was during the procedure.
Exactly. And one of the things that forgot to mention earlier is a lot of your offices are placing air purifiers in each of their operatories. I know in our particular location, we have one in each room that is used to help cycle the droplets out of the air. And we have also, offices are installing ionization units in their heating and air conditioning systems, which allow for, it pulls the particles together and allows them to be bigger so that they're getting trapped in the HEPA filters and not allowing them to circulate. Did your clinic offer anything like that, Natalie?
Yes, we've revamped our HVAC system for a better filtration of the entire clinic.
Wonderful. All right, so the last category here, and one that's probably gotten a lot of attention from everyone, is personal protective equipment. And that's important because it protects the worker from the hazard. And we've seen an increase in gown usage, both disposable and washable. Gloves, masks, you have your level 1, 2, and 3, as well as your KN95 and your N95 masks. Face shields are much more prominent now. Goggles, especially you want to point out the importance of the side shields on your goggles. As Natalie pointed out earlier, we're seeing more head coverings being worn. And as I mentioned, the KN95 and the N95 respirators are very important. Any personal protective equipment that I'm leaving out, Natalie?
Some offices are utilizing shoe covers also.
Okay. All right. So one of the most important parts of personal protective equipment is proper and effective usage. And donning and doffing is particularly important so that there's not cross-contamination. There are a lot of great resources out there that you can use to make sure that you are donning and doffing properly. Fit testing is an important part of respirators. A lot of offices may not be aware, but if you are utilizing an N95 mask in your office, you should be doing an initial fit test, and along with that, a medical evaluation just to determine that everyone in the office can be safe as they're being asked to wear the N95 respirators. And then also at the very least, you should be doing a user seal check. This was fairly new to me, and I had the opportunity to listen recently to someone explain it very thoroughly. And it's a relatively easy thing that you can do as an individual. Basically putting your hands over your mask and breathing in, you should feel it dimple, and breathing out, you should feel it fill up, and without any air coming around your face. Anything you wanted to add there, Natalie?
Just with the medical clearance, I know my clinic did it, and in getting the medical clearance from my medical provider, they were a little surprised that dentistry was going to that extreme.
Wow, okay.
Yeah, regarding the clearance.
Interesting. Now I know that there are companies that are offering medical evaluations online. 3M, I believe, offers something in that way. So there are different resources you can use in order to get these medical evaluations. As far as the fit testing, Natalie, many people have had questions. They've seen things where they thought the fit testing was being waived. And it's important that we point out that the initial fit test is still required. It's the annual fit test where there was some waiving of that. Is that correct?
That is correct.
Okay, all right. And again, Natalie and I will both offer our contact information at the end of the course. If you have any further questions, please feel free to reach out to us. There's a lot of information that could be provided. It's just that in the sake of time, we can't provide all of it right here. All right, now it is important to note that there are risk factors associated with PPE usage, and two of the most important ones that stand out are heat-related illnesses and physiological impacts. As all of this was happening and people were coming back to work, we were entering into the summer months, and individuals were finding that they were running into a lot of different problems with the heat and wearing all of the new PPE. So according to the CDC, the wearing of PPE increases the risk of heat-related illnesses. And reasons include sweat evaporation, excuse me, the body's normal way of getting rid of heat is reduced. Also, body temperature increases because excess heat and moisture is held inside the PPE, And the extra weight of PPE increases the physical effort to perform job responsibilities. What are some other things you can think of within this category, Natalie?
Just being physically exhausted from wearing the N95 masks in the beginning.
Thank you. So some of the physiological impacts include hypoventilation, an increase in blood CO2 levels, which can lead to headaches, nervous system changes, which can lead to decreased situational awareness and difficulty coordinating sensory or cognitive abilities and motor activity. And you might not even be aware of these things happening. So that's why it's important that as coworkers, we're all keeping an eye on one another and making sure that we remain as healthy as we possibly can. Anything you'd like to add here, Natalie?
Just that there are also some psychological aspects to wearing the increased PPE. For those individuals who may suffer from anxiety, their anxiety levels may be increased just with the feelings of suffocation from the increased PPE. So just something to be aware of if you know of a coworker that may be normally dealing with anxiety, their levels may be increased during this time.
I've definitely heard the same thing, panic attacks increasing
Yep.
and increased anxiety, most definitely. All right, so some of the factors to consider is the type of PPE being worn. For many of us, gowns were not something that we wore on a regular basis. Is it the same in your clinic, Natalie?
That is correct, and now it is being worn routinely and changed after each patient.
Wow. And do you use disposable or do you wash yours in your particular clinic?
Oh, we wash them.
You wash them, okay. All right, and also a factor to consider is the duration of usage. How long is the item meant to be worn, and how long is it actually being worn? As we were speaking earlier, business assistants are wearing masks, and while they're not the N95 or the KN95, it is definitely a challenge when you're not used to wearing a mask on a regular basis. You also want to consider the team member's work rate. Is it a fast-paced procedure where they're going to get overheated very quickly, or a lengthy procedure where the wearing of the mask for such an extended period of time for the KN95 or the N95 can lead to the physiological impact that we had mentioned earlier. And also the fitness and hydration level of the individual really needs to be taken into consideration. And I believe, Natalie, correct me if I'm wrong, but through this whole conversation, I think one of the things that might be the most important that we can say is really take care of yourself. Make sure that you are staying as healthy as you can, eating right, and make sure you're getting the rest you need. These are all important factors in being able to stand up to whatever illness may come your way. Would you agree, Natalie?
I would, and one other thing I would add is be cognizant of any mental breaks that you may need throughout the day, especially if you're newly returned back into the clinical setting after being away for some time. Psychologically, it's difficult for many people.
Most definitely, and that's why CDC gives some great recommendations. We're going to be offering some references at the end for you to check out, but they really place an emphasis on self-care and finding that balance between the protection that PPE provides and the burden of that PPE, and learning to deal with that and adjust to that. So it's important. Speak to your office, speak to your dentist, speak to your office manager, and make sure that you're getting the fresh air breaks that you need in order to take a little bit of time to be out of that mask and actually breathe some fresh air. You know, we may have to rotate you know, give one another the time to step outside and take a deep breath and just be able to get that fresh air, so that you're not constantly just rebreathing your air all of the time. What other features would you add, Natalie?
If you have the opportunity on your lunch break to go for a walk, if the weather is good, would highly encourage it. Does not only the body great benefits, but also the mind.
Exactly. One thing that's important to remember is as we're getting ready to go into a time of the year when the heat is going to be on, and you always have that challenge with the dental assistants, the clinical assistants, and hygienists in the back that are in all of their PPE gear, trying not to get overheated, while at the same time your business assistants at the front are finding it, who are near that front door, may find it a little more challenging because they are a little cooler. So you're going to have to find that happy medium in order to make sure that everybody is safe and well.
Wear layers.
Wear layers, exactly. An interesting point that I saw while I was doing the research for this was the little gel packs that you put in the refrigerator and give when you've done an extraction. They
Yep.
are recommending that you place those not against your skin because you don't want to, you know, burn your skin or anything, but place those within a layer of your clothing to help cool you down. They're recommending that you have an iced drink perhaps before you change into your PPE to bring your core body level down, temperature down. So different things like that you want to just keep in mind. It might be interesting as a team to try and determine different ways at your next morning huddle, how you can keep an eye on one another and come up with solutions to meet all the challenges that are occurring with the PPE wearing. So two really great resources is the dental check that comes from the CDC. You can get that as a mobile app, as well as OSAP, the Organization for Safety, Asepsis, and Prevention, has created a best practices for infection control in dental clinics during the COVID-19 pandemic. This is a great resource. It talks a lot about the hierarchy of controls that we had mentioned earlier. Plus, both of these resources give you checklists to make sure that you are using the best practices for all of the different categories that we talked about, as well as all of the different challenges and obstacles that we're finding as we move forward. Anything you want to add about these two resources, Natalie?
They're both excellent resources, and I've referred to both of them before.
I use them both very frequently. All right, so anything at this point in time you'd like to add, Natalie?
Nope, we've covered it all.
All right, so here are some great resources. Your NIOSH, your CDC, great information. OSHA, OSAP has some wonderful information. And we just would like to thank you from the American Dental Assistant Association and from myself. If you need to reach out to me, my email is rrixse@adaausa.org. And Natalie?
Mine is NKAWEC as in cat, KYJ as in John @gmail.com.
Wonderful. Thank you so much for being here. Please stay safe, be well, and again, if you have any questions, feel free to reach out to us both.
Thanks, everyone.
Good night.